Hey guys, so if you just watched the last lecture on conditions of the musculoskeletal system, you'll see that I'm still wearing the same shirt because I'm recording these back to back. Some of you might be watching these back to back, some are going to spend some time in between. But that's what I'm doing. So let's talk about chronic pain. If you watched that one, we talked about pain, so I think I can move through this a little bit quicker because I mentioned some of the things back there, but nevertheless, I want this. This is kind of an introduction to the concept of pain, and it's such an important process of not only emotional but physical pain. So for those who are going to do mental health therapy specifically, or if you're working with people with physical pain conditions, this kind of falls into both categories. Of course, the book talks mostly about physical pain, but we're going to add in our own little parts here too. So the first thing that we should probably just say out loud is that pain is subjective, and we all know that, but it's really important to understand what that means for us. So we're going to talk about that as we go through here. What does the subjective experience of pain mean for how you work with somebody who has a low or high pain tolerance or whatever? Different conditions for different situations, or different strokes for different folks. That's another way to say the same thing. There are some ways to understand how we respond to pain, or a person's response to pain, I should say. There is the pain perception, or the awareness of pain. So, does a person even like perceive that they're experiencing pain? Some people don't. Have you ever got like a bruise on your leg or been cut, or all of a sudden you realize that like there's some thing inside of your mouth, like a cold sore or something? And you're like, oh, that's been around there for a while. I must have got a bruise on my. I don't know when that happened. Like we experience things that otherwise might be painful, but we don't even notice them. Some people notice a lot more than other people. Some people notice a lot less. So the experience of pain or the awareness of it is one part of what the overall response is. Then there's a pain threshold. In other words, I don't really feel pain until it reaches this certain level. And at that level, that's when I notice it. I'm a person who doesn't mind getting my blood drawn or like getting needles stuck into me. It just doesn't bother me that much. It like, oh, you feel it and like it's there, but it's not a big deal. Whereas my mom, and maybe some of you, when she gets a needle stuck in her, she's like, oh, oh, and she like has, is really super dramatic about it. Just winces really hard. It's the same needle, same size, but experience is very different. So her threshold for feeling something is a lot lower than me. Also, I used to come up behind her when I was younger. I used to come up behind her and like, they do that thing when someone's standing up and you like knock the back of their knee and they kind of like fall over a little bit. I used to do that to her all the time. And she's like, oh, that hurts. Don't do that. Ugh. And I don't think it actually hurt her body, but I think it sort of like maybe hurt her ego a little bit. I don't really know, but nevertheless, like she had that threshold and said like, ouch, that hurts, even if, it, regardless of whether I think she was in pain or not. She said it hurt, and so that matters, right? That threshold. As somebody gets this stimulus and their threshold is right here, there becomes a point when that pain increases where they've reached their tolerance, where that pain is no longer bearable, right? So some of you maybe done this where you stick like, what's a good example? When I was in like 10th grade or something, I took an electronics class, and we took ourselves up to a what do you even call it? A thing that like increases voltage. So then you like put it on your skin. You're like, oh, I can take 1 volt and 2 volts and 3 volts. But at some point, you're like, I've taken so many volts of electricity that I'm like, I'm done. I can't do it anymore. That's my pain tolerance. So somewhere between the threshold and the tolerance, we know it's there and we experience it, but then it becomes too much. That's where most of us live, right? And some of us live even beyond our tolerance, which is where people get really desperate and do some interesting things that we then deal with in counseling. So we'll talk about that later. And then we talk about pain intensity, pain severity. Subjective, kind of self-explanatory, we've covered it. Okay, when it comes to understanding what pain is, not just the subjective experience of it, we're talking about how long does that pain last? If you were watching that last lecture on musculoskeletal system, you heard my analogy about getting punched in the arm. The punch in the arm, like when I do this, I'll feel it, and I'm still kind of feeling it, and now it's for the most part gone, right? So my duration lasts for a few seconds. This This is both true of emotional and physical pain. Think of somebody who loses a loved one. The pain duration of going through the grief process might be really long for some people, might be really short for others. So both psychological and physical, the duration of pain matters. The location of pain matters. This pretty much relates a little bit more to our, we have a better understanding of our physical locations of pain. It's in my toe, it's in my fingernail, it's in my head, it's whatever. When it comes to location of a psychological pain, that's a little bit different thing. When we're sort of navigating, is this pain is this like you could think of it like an attachment injury. My ability to trust, that's like a psychological function of of us as people, right? If I'm going to be a social person, I have to have a functioning ability to trust other people. If I've had attachment injuries based on people who have lost my trust or done something to me, so trauma does this, it severs the ability for somebody to trust. So the location of pain in that person's life comes from that attachment injury, and we can identify it as distrusting or distrustworthiness or something like that. Whereas, as another example, if somebody has some self-confidence issues around their body image, my self-concept, part of my self-concept is not only my self-esteem, but knowing what my physical container is and how to have a relationship with it. So the location of my emotional pain might be around a view of my physical body, which might come from things like body dysmorphia or something like that, or somebody's experience of their own gender, those kind of things. The ability to trust, the relationship with the body, those are two different sort of like psychological locations. So that's what we can be thinking about when we talk about location of pain psychologically. And then, of course, the cause, probably self-explanatory. We could talk about that one for quite a while, I would imagine, but we're not going to here just yet. Also, when it comes to pain, culture really matters. The way people express their pain, even if they experience it the same way, the way that they express their pain might matter. So let's pretend that my mom and I experience getting poked with a needle the same exact way. It hurts. We have the same threshold. We have the same tolerance. We have all the same experience of pain. And yet, me as a dude, I come from a very manly American culture. It's not true, but let's say I did. I mean, I come from that culture, but I'm just not that manly. I don't have a lot of that machismo, right? So I don't get very stoic when I have pain. I don't say like, you suck it up, you hold it down, you deal with it. I don't have that kind of stuff. I come from a culture, like a counseling culture, we could say, where free expression of whatever that pain is okay. And it's okay to talk about it. So sometimes when I come out and I say, I feel the pain, but it just doesn't really bother me that much. But it's like maybe a 5 on a scale of 10 or whatever. And doctors love that because in the culture of the hospital room, they really appreciate that. But when I go to, when I'm, riding the subway, hey, I don't ride the subway. When I've ever been in a public place, let's just say that. If you're in a really public place, to start talking about your pain and your tolerance of it and all that kind of stuff, or maybe your emotional pain, it's even more uncomfortable for people. People freak out about that, right? So cultural consideration really matters, and how a person expresses it is part of this equation here. We're talking about this stuff. Sometimes, this is a really common thing when I do vocational interviews to understand a person's disability. Sometimes you'll have people who are just like, oh, it's especially for forensic settings, it's the worst. So-and-so did this to me, and they deserve to compensate me for all the pain that they've caused, and, all that stuff. And they're just over the top about it. Other people are like, this thing happened to me. I can just keep going to work. I don't want to think about losing my functional capacity at work. And so I just deal with it. It's not a big deal. And I have to say, in both situations, let's find that middle ground here. Because in one case, you can do more than you believe you can. In the other case, you need to slow down, and it's going to affect you more in the long run than you actually think it is. So let's get real about this, right? So there's a balance there somewhere. Getting to the root of the objective understanding of what that pain is and what the future implications are and what the current limitations are, that's really what rehabilitation counselors in those settings are really helpful for. Different kinds of pain. Neuropathic pain is the result of, these are kind of confusing, by the way. These first three are related here. Neuropathic pain is the result of irritation or injury to tissue in the central or peripheral nervous system. In other words, it has to do with your nerves, all right? So that's neuropathic pain. A nerve gets poked or it gets broken or something like that, and it hurts. Pretty easy to understand that one. Nociceptive pain is a little bit different. So this is pain resulting from irritation of pain receptors in somatic structures. For example, I typoed there. Pain in example, skin, ligaments, joints, or bone. So think of like a bone fracture. Your bone doesn't really have nerves in it, but it'll still feel painful. And I guess you could kind of think of it like as secondary pain, but the primary source is the bone break, but it still feels like it hurts, even though it's not really, there's no nerves in that particular thing. So it's, it's a little bit strange to think about. At least I have a hard time sometimes wrapping my head around it. And then there's, of course, mixed, which is probably more common that somebody would have a mixed experience. Your bone breaks, there's no nerves in it, but if you feel this kind of like deep ache, and it also might poke other nerves that actually do get broken and do sort of get send back signals to the brain through your nervous system and all that kind of stuff. So we talked about in the last chapter too, acute versus chronic. The thing in the last chapter they said about chronic pain was that it's any pain that lasts longer than 6 months. And that's really not that descriptive and that helpful, because some pain might last longer than 6 months, but you'd expect it to. Like if somebody had a spinal cord injury, you're going to expect that pain to last longer than 6 months, right? It's just probably part of the condition. And yet, if somebody gets a hangnail, that hangnail pain, if it were lasting longer than 6 months, you'd be like, something's not right here, right? So setting a number to the duration is really kind of, just something that's helpful to me. Whereas if I have a condition where there's a period of expected healing, and then I go beyond that period, then that would fall into this category of chronic. It's just sort of longer lasting than it should last, something like that. Also, I mentioned in the last chapter too, it's not just about lasting longer than you're supposed to, but also this idea of functional purpose of pain. So in a lot of cases, pain can be really helpful because it tells me not to do something. The example I've used before is you are walking down some stairs, you roll your ankle, and your ankle sends a message to your brain that says, hey, whoa, let's slow this down because I don't want to continue to hurt, or I don't want anything else bad to happen. So be careful with me. And you say, okay, well then I, raise my ankle and put some ice on it, whatever. And then later on I feel better. And the pain really helped me out because it told me what I need to be cautious of. In some cases, there is pain that doesn't really have a supportive role, or it doesn't really help you protect something, or it doesn't really warn you of something that should be changed or different. And so that's another consideration of chronic pain. If it's doesn't have a specific purpose. An example of this would be like fibromyalgia, which we've talked about. Fibromyalgia, we don't really know what the pain is there for. It's thought to be sort of a problem of the processing somewhere in the central nervous system, which means it doesn't give you helpful information about what kinds of activities you should protect. Like if your ankle rolls, you know to protect your ankle. But with fibromyalgia, the pain might move from one location to another and might be experienced more or less intense at different times. And so it's not necessarily telling you, hey, be careful of your arm because you're doing something wrong with it. It's just going to be in pain for a while before it moves on to some other place. Does that make sense? So it's another thing to think about too. Pharmacological interventions, antipyretics. We've talked about non-steroidal anti-inflammatory drugs like aspirin, acetaminophen, that kind of thing. Anticonvulsants, antidepressants. These can be prescribed even if depression is not necessarily an issue. So sometimes these can even help with physical pain for various reasons. Sometimes it might just be that some medication helps with sleep, which then helps give a person the best opportunity to have new emotional attitude throughout the day, to cope with pain better, to make better decisions throughout the day. Sometimes it's legitimately sort of dulls a little pain or has anti-inflammatory properties. So there's all kinds of reasons to use these that are not necessarily just for depression. Corticosteroids, we talked about them. They're meant for short-term use because steroid use is not good long-term. It has potential side effects. Here's a few listed. Gastrointestinal bleeding, potential increased glucose levels, and then potential contribution to osteoporosis or conditions like that. We've all probably heard about the opioid epidemic, opioid analgesics. They can be effective short term. They're very important in the management of pain because if anybody's ever had something really painful happen to them, you know what it's like to experience that. You know that it can have some long-term consequences to live in that pain for longer because your body can only handle so much before it starts to break down. In other words, think of this physical example before we lead to an emotional one. Physical example would be if you experience pain in your shoulder and you tense up a lot and you're just like ultra protective of it because you don't want it to hurt anymore, but you can't really help but like maintain that intensity. But what your body needs to do is relax. If you take some drugs and get really high and you just kind of lay there and float, it allows your body the opportunity to just kind of chill out for a little bit. And yet, being high and floating is not really a safe thing to do. It's not going to help you in the rest of areas of your life. So you have to know when it's appropriate, when it's not. So it can have a very important physical benefit to you. Allow your body to do things like relax when it's supposed to. And be sort of protected from moving around too much. Sometimes that's the reason for taking it. And then psychologically, if you take those opioids, I haven't drank water in a while. If you take those opioids, it can protect you from getting overly angry, to being too irritable, from getting frustrated and just not being able to deal with all this hospital bullshit and wanting to take the IVs out of your arm and blah, blah, that kind of stuff. Because when you have those emotional reactions, they lead to physical consequences. And so sometimes those drugs can be really helpful short term in sort of managing both physical and emotional conditions, just allowing you to say, like, this is good for now. I'm glad I have this, but I can't live like this for long. We could probably spend a whole entire day, maybe even a whole class. Maybe a person could specialize their entire career in pain medication, addictions. A lot of you are LACs, so I'd imagine you have a lot to say about opioids and their addictive properties and what it looks like long term after somebody gets hooked on these. So much more to talk about. Other interventions. Physical therapy, obviously. Electrical nerve stimulation, or if you've ever heard of a TENS unit, it's like a little box. You put like a little electrodes on your skin in different places, and it stimulates the nerves. It's not painful, but it just stimulates the nerves. It kind of like, does the things. I had a friend who had something like this. They used to sell these things to people who wanted to get in shape, where it like flexes your muscle and then releases it and flexes it again. And when you crank it up and you put them on your cheeks, it does really funny things with your face. So he had one of these, and we used to play with it at his house, where we'd stick them on our cheeks. It wasn't exactly the same thing, but it's kind of similar, I think. But anyway, the idea is that if you stimulate the nerves, it doesn't really hurt you, but it blocks those pain impulses from getting from one side to the next. It would just be like saying, there's an accident up ahead, and we don't want to have to deal with that future accident, so we're going to block the road and detour you around it, that kind of thing. Only in this case, it doesn't even detour you. It just says, we're not going to go through that because we don't want you to have to see that accident or something. So just blockages. Biofeedback is becoming more and more used, and there's really good research about its potential for helping with things like both psychological and physical pain. Basically what it is you hook your body up to some metrics that you can actually see, like your blood pressure and your heart rate and all those things, and then you introduce yourself to painful events, either emotionally or physically, and you watch the numbers on your heart rate, for example. You watch that increase. And there's all kinds of different metrics you can use, but just heart rate is one example. You watch your heart rate increase, and then you do some relaxation exercises and watch when it goes down. And maybe if you think about fuzzy little teddy bears, you're like, that doesn't really help my heart rate go down. It's still kind of up there, whatever. But when you think about puppies puppies. They're so nice. You know what I mean? So then you can say, well, puppies seem to be the thing that really helps me calm down a little bit and not respond in this painful way or that exacerbates the pain. So my intervention now is I need puppies because using the biofeedback machine, I found the thing that really helps me relax. So that's just an example. Another example I've heard people use these biofeedback machines are for PTSD. Excuse me. For PTSD, when you have when you re-envision a traumatic experience, or whenever you see somebody who looks like your perpetrator, or you have to go home, you go see your in-laws for Thanksgiving, whatever the painful experience is. When you think about that, it kind of sends you into that trauma experience where you're like heightened nervous system, and you have these flashbacks, and you maybe have nightmares at night and all this kind of stuff. If you can experience, this is very much like EMDR almost. If you experience that thing again, but then you get to watch your body respond and learn about the things that help you calm down, then when I'm outside in public and I don't have my therapist with me and the biofeedback machine, I can say, I see my in-laws, but as long as I have enough puppies around, I know I'm going to survive. So the therapeutic intervention is puppies at Christmas. It's a dumb story, but you guys get the idea, I think, right? You can also use acupuncture, nerve blocks, so local anesthetic injections that just sort of block the nerves for a period of time, so you just can't even feel it. Kind of like the TENS unit, only it's chemical instead of electric. And then surgical severing of nerves, that sometimes is sort of the last course option. When nothing else is working and the pain is too unbearable, sometimes you can just sever the nerves, and that sort of helps fix things. Other consequences come from that, but nevertheless, it's an option. I want to mention a note on marijuana because it's now legal as of January 1st, 2020 in Montana for recreational use. It's been legal for medical use, and it's kind of spreading across the country as far as like medical and recreational use. It's being promoted as a pain management medication. I have seen both positive and negative opinions in the science, right? And some science initially is oftentimes kind of like public opinion. You see a whole bunch of opinions either way. This study says it's good, this study says it's bad. You really can't know a whole lot until there's been a lot of research, until you really sort of get confirmational studies that say, yep, this one seems to have been done in a very controlled way, and I'm getting the same results, and here's 5 other studies and 10 other and maybe 100 other studies that confirm the same thing. And by that time, you really get a better understanding of what's really going on. But I will tell you my opinion on it right now. So what I've seen, or that's not even really my opinion, my understanding of what I'm reading from other people. What I'm seeing is that marijuana is a potential, it can be potentially beneficial for some conditions. However, and it can be beneficial for chronic pain conditions. But the thing that I think is going on, or the thing that I understand is going on from other people's reports, is that just like alcohol, you lose a little bit of your memory because you can't feel things for a while, and it kind of numbs it out for a little bit. But there are also potential consequences. Now, one of the long-term consequences of marijuana use is potential for addiction, although you'll have plenty of people who says it's not addictive. But it seems like there's potential for long-term use to be an addiction, essentially. It's in the DSM-5 as a substance use disorder. But there's controversy around here, so I'm trying to be careful about how I say this stuff too. But potential for long-term addiction, it has some memory implications potentially, social implications for sure. Some of those are not necessarily caused by the marijuana itself, but by the way that our culture looks at it. So there's that part to complicate it too. So there's a lot of stuff that we just don't know about it, and it's being prescribed illegitimately a lot of times too. So, you'll get a doctor who says like, yeah, whatever, I don't care. It's your life. It's not mine. Go smoke as much as you want, or eat as much as you want, or use the topicals, or whatever you do. I don't know. I'm still a little bit reluctant to say this is something that's it's a good idea to be used as widely as we thought opioids were, because we don't really fully understand the long-term consequences. So what I think I'm reading from other people, and my personal opinion based on what I've read, is that it can be sometimes the thing that really helps people, and it can be really wonderful. And when we're weighing out the pros and cons, remember, sometimes the pros can outweigh the cons. And in those cases, you're just like, yeah, okay, I get it. Go for it. In other cases, it's just not a good thing for people. It's not a good thing for us. It's going to have some long-term consequences, not just for the people who need it and who are, living with the need for it, I guess, but for all those other people too that don't really need it, but they're getting prescribed it illegitimately, and they think they do, and they think it's helping, but they're not really aware of the risks of later on and all that kind of stuff. So I'm kind of on the fence about it. But I guess you could maybe make an argument for a lot of these things too about like, yeah, it's not good for this, it's bad for that. And that's just where we need a little bit more knowledge and maybe a little science and a little time and experience and all that kind of stuff to go along with it. So I don't know. You guys make your own opinions about it, but those are mine. Psychological interventions. Okay, this is where I want to spend a little bit of time, albeit not too much longer, because I know you've already watched, for those of you that are taking this in the class, you've already watched an hour and a half almost of lecture. Too much time spent with Aaron. We don't need that. Counseling. The book says, oh, counseling can be a good thing, but for us as counselors in a counseling training program, we're like, what the heck does that even mean? Right? It's like, yeah, I get it, but what kind of counseling? What do we actually do as counselors? That's the thing that I would love to spend more time on. I explained a little bit of this in the last chapter, so I'm not going to go through it here, but they mentioned CBT in the book. CBT is the intervention. Well, what does that even look like? We need to know. Just like when they say, well, you could inject local anesthetic into the site. Well, an anesthetist would be like, well, or anesthesiologist, whatever the difference is between those two. They would want to know, like, okay, well, how do I put the needle in? And how much do I put in of which kind of drug? And they need to specialize in that, right? As counselors, we need to specialize in what are these conditions. And I just don't think we get enough. But you will have other classes where you can supplement that class stuff with this class stuff and kind of figure these out too. And with some practice, this stuff will come as well. Stress management. We've talked about that. Remember the locus of control stuff that we talked about? So managing outside stress, what we have control over there, managing our response to stress, that can be a big part of that too. Guided imagery, that can be the guided imagery, relaxation therapy, meditation, hypnosis, all these kind of fall into the category of like, where do you put your mental energy and how do you direct it in such a way that helps you function? So helps you stay calm when you want to get worked up about something, or you want to like get really tense about something, but you just kind of chill out a little bit. You need to have some adaptability, make some smart decisions about what your limits are. All these things kind of fall into that same similar category. Guided imagery specifically is like, I once worked with a guy who he wasn't really sure exactly what he had, but I think it was CRPS, or chronic regional pain syndrome, which is kind of like fibromyalgia in that we don't really know a ton about it. It's very subjective in the experience of the pain, and it comes with certain conditions like certain kinds of pain, also potential for skin sores and migraines and that kind of thing, but he had something like that, and he always felt like his left arm was just on fire, just burning all the time. Tingling, numb, but also like burning. And so he had to, in the middle of winter, and ironically, cold made it worse. So he would wear, even when it's like, 60 degrees out, he'd wear a glove on his hand. And so I would talk to him about it, and I would say, okay, look, we can talk about your anger and frustration, all that kind of stuff. But right now, you're so hyper-focused on your arm that we need to figure out what to do with that. So let's learn a little bit about your relationship to your pain. And so one of the things we did was I'd walk him through this guided imagery thing and say, okay, give your pain a name. And let's picture something. What do you think of when you think of your pain? And he's like, it kind of moves around like the Tasmanian devil. And I was like, okay, that's great. Where do you see it? He's like, oh, it's like right here on my arm. You can't see this. It's like right here on my arm. I was like, what do you call it? He's like, Taz. We'll call it Taz, the Tasmanian Devil from Looney Tunes. And so we're like, okay, where's Taz right now? What are you going to do with him? And so over time, one of the things we'd work on is like, okay, if you take this little Tasmanian Devil, pretend you're picking him up with your hand and you're going to, eat him or throw him away or stomp on him on the ground or whatever. And he would sort of practice that. And over time, in practicing that, he gained a greater sense of control over what do you do when your pain comes. You think of it as this Tasmanian Devil, and then you do something with that imaginary thing, and it can help kind of either occupy your mind or get your ability to think about something other than this thing that wants to take all of your attention. It didn't necessarily change the intensity of his pain. That wasn't the goal. The goal was to increase his ability to figure out something he can do during a painful experience, something like that. And also, we didn't get to work through this, but the next thing I probably would have done with him, had that successfully been working for him, would be, okay, let's change your attitude, basically. You now can be mad at the Tasmanian Devil and not the pain, but think of the other things that come up when you get when you feel that, which is anger, frustration, irritability, all that kind of stuff. You can control the Tasmanian Devil, but now can you control yourself and the way you react to it? And he was already kind of doing some of this by himself too, because he would come in and be like, I got to find a better way to be when I'm in pain. I got to so he was kind of already advanced along in that process a little bit. But that was just an example. I could probably talk about many of these for quite a while, and I'd actually like to, but I think I'm not going to just for the sake of the time. You'll hear about relaxation exercise, progressive muscle relaxation. Yoga could even fall into this category. Sleep meditations. There's probably just a bunch of stuff that would fall into these categories. Hypnosis is one worth mentioning. Hypnosis is one of those activities that was big for a while. It has been kind of discredited by a lot of people as being potentially manipulative and not really person-centered, which a lot of us as counselors think we are. However, there are proponents for hypnosis. Patty Nichols, who some of you might have for internships, she does hypnosis, and she can talk to you about what her experience of it is. I don't know. You make your decisions. This is, again, another one of those, okay, hypnosis, yeah, there's pros and there's cons. There's risks and there's rewards, just like with opioids. So is it terrible? Is it wonderful? Is it the worst thing in the world? I don't know. Pros and cons, right? So you guys get to make some decisions about it yourself. I've never been hypnotized. One of the criticisms is it's just like hocus pocus kind of magic stuff. It's all fake, whatever. I don't know. I have a friend who I trust really well, and he was hypnotized in high school by some guy who came to do a thing, and of course they make him do silly things on stage in front of everybody else, whatever. But he swears by it, and I don't know. I have another friend who's seen a ghost, and I don't know. I don't see ghosts. I don't believe in that kind of stuff. But whatever, who cares? He does. Sometimes the placebo, even if it is placebo or not, whatever, it doesn't really matter. It just people get better, right? I don't know if I told you this in this class, but if you measure a person's experienced benefit of counseling, there has been some studies where they say, okay, you come into the lobby, we'll get you an appointment, and then you're not going to see anybody. Now see if you feel better. And people feel better, right? And then you go into one session of counseling, and that's good, and then 2 sessions are even better. And there's kind of this progressive scale of improvement the more time spent in therapy. But some people, just by knowing that they're going to make the decision in their head, not even getting into the lobby, not even having an appointment, but just by saying okay, I'm ready for counseling, I willingly accept the support and help, people tend to improve, even just by that little bit. Is that placebo? Probably. There's no sugar pill even. It's just a change in mindset, right? So some of the stuff, psychological intervention for pain is sometimes just placebo. And if that's enough, maybe that's okay, You guys make the choice on what you think about that. Operant conditioning, we know what that is. Person experiences pain, you squirt them with a squirt bottle until they hate it so much they stop feeling pain. No, I'm just kidding. That's not how that works. It'd be funny if it was. Risk and rewards. You reward a person for doing something that's good. It's kind of like biofeedback that we described earlier. And then pain support groups. Those can be crucial. Having other people that understand how frustrating it is to not be able to go to the grocery store because you're having an episode, or not being able to drive in the car to go on long vacations with your spouse like you used to. Frustrating. Other people that can identify with that. Support groups are so important to the social fabric of pain experiencers. So there's all kinds of different kinds depending on the kind of pain you have, but whatever. Somewhere between 30 and 60% of people who have pain conditions experience depression. And so by the time they get to you, you're going to look at that and say, oh, this is depression, so like you're not motivated, and are you feeling suicidal, and all that kind of stuff. And what you can be thinking of is, okay, where did your pain come from? What is that like? And all these things that we've been talking about. What's your relationship to pain? What's your attitude? What's your locus of control? All that kind of stuff. So there's one argument to be made for like treat the depression itself. Another argument to be made for understand the pain and treat the pain with psychological intervention and understanding, and the depression will go away. What that means, if you're thinking like, wait, what now? What that means is a little more complicated. And I'm not going to talk about it here, but just know that depression can limit pleasure and motivation, but it can increase guilt, anger, isolation, loss of self-esteem. So talking about those things with somebody who's experienced this stuff or who is in pain is part of the intervention. Say, tell me about how you feel about yourself. When do you feel terrible about not being able to do the things you used to do? What are your emotions around your own capabilities and that kind of stuff? I would never ask that question because it's real dorky. I don't think anybody would know what to say to that. But I talk about those topics nevertheless. By the way, I guess it's worth mentioning. Sometimes they say like, person walks in, they say, I have back pain, whatever. And you're like, well, have you been isolating? And they're like, yeah, I guess so, whatever. But I hate those questions because they feel like a checklist or some like initial interview question. But I do like asking about, so where do you spend your time? Oh, you spend it at home quite a bit. Oh, who's around in your home? Well, nobody. They all go out and do stuff, and I just get to stay home. And you're like, okay, well, do you choose that, or do they choose that? Well, I could have went with them, but I decided to stay home because I was in pain. And I know that they're isolating because they just told me, but I don't ask, like, are you isolating? Because people are like, no. Sometimes people are, but most of the time you pick it up via context by asking questions like, tell me about your life. What's your story like? Where do you go? Where do you spend your time? Who's around? All that kind of stuff. So when we list out these things and I say, ask about guilt and ask about anger and isolation, all that stuff, most of the time it doesn't really come out like that. You just sort of pick up on these trends, themes that come out of a person's story, something like that. Another functional implication is impediments to effective management is access to professional treatment. Okay, this is a big one. If somebody doesn't have the income to be able to afford a physical therapist and an occupational therapist and a rehabilitation counselor, they can't afford the medications, whatever. Poverty affects a person's outcome with the ability to manage pain, right? And we know that when people are in pain, they're often more desperate. And desperate times lead to desperate measures, which is what we learned from Charles Dickens, who knows nothing about pain. Well, he does, but it's beside the point. People get desperate and they do different things. So a person lives in poverty, experiences some kind of pain, and then gets desperate, and then needs money to deal with the pain and whatever, and then they go to prison. But I mean, you can see where this goes, right? Poverty and the inability to access financial means makes the pain worse, can increase the pain. So that's worth spending some time on, but I'm not going to right now. Geography. If I have a hospital and I live in northern Montana, it's 4 hours away, I'm not going to be able to get down to the doctor as frequently as I could in order to manage the pain successfully, right? So geography makes a difference. What if there are just not enough doctors? What if there's so much emotional and social pain in our culture, but we don't have enough therapists? So lack of overall resources. That affects an individual's ability to manage their pain. So all of these things, and there's probably a ton more of impediments or reasons why we can't effectively manage this stuff because we don't have the right professionals, we don't have the right science, we don't have enough money, we don't have all the things that we maybe need to do this. Now, there's also an argument to be made for it's not that we don't have enough money, it's that we have too many cell phones and people are so focused with their money on their technology that they're impeding the ability to really connect with other humans, right? We've been hearing this argument about technology for years. So that could also be true. But nevertheless, pain is happening, and people's ability to deal with it is impeded for all kinds of reasons. Also, common story, mentioned this before in different contexts, but common story is somebody gets in an accident, experiences a bunch of pain, they get a settlement, and instead of putting all that money towards future physical therapy, they buy a truck. And so sometimes impediment to effective management is people's dumb decisions or poor financial planning, something like that. Vocational implications. I feel like this is just sort of preaching the gospel of rehabilitation counseling, but getting back to work can really help with a lot of these psychological consequences. Like a person experiencing depression, they're isolating too much, but if you can get them back to work, they might not experience that depression as much. Reverse the downward cycle. Can provide meaning to somebody, so making them feel like they're a contributing member of society or their family or their church community or their city or whatever it is. It doesn't have to be that they have to get back to meaningful competitive employment right away in terms of money, but if they can spend some more time at their church sitting handing out flyers when people walk in the door, or whatever they call it, the church bulletin, whatever that thing is. If they can volunteer at the food shelf, if they can, whatever a person can do to contribute and give back is part of like maintaining your vocational skills still, right? So it doesn't have to be just, do you have a job, but do you do a meaningful activity that provides you some value and somebody else value in the process? That's essentially what work is. We just often equate that with monetary exchange, but it doesn't have to be. It could also give a person structure, increase their motivation, et cetera, et cetera. So all the things we've talked about in terms of maintaining functional capacity and maintaining the social fabric that often gets lost after in the experience of pain, work can do that for people too. Okay, now we are done. Thank you for spending this much time with me. I know it's been a long haul because we've got 2 kind of longish lectures in this chapter, but I appreciate every moment of your listening ears, because you're going to do good things for other people, not that I care that you're spending time with me. I think this is hopefully going to help you do good things with other people. So anyway, talk to you soon. See ya.